Welcome to the New Chemist podcast.
We are so glad you are listening. Feel free to subscribe on Spotify and tell your friends and colleagues about the podcast.
Our Deepest Fear by Marianne Williamson. Our deepest fear is not that we are inadequate. Our deepest fear is that we are powerful beyond measure. It is our light, not our darkness, that most frightens us. We ask ourselves, who am I to be brilliant, gorgeous, talented, fabulous? Actually, who are you not to be? You are a child of God. Your playing small does not serve the world. There's nothing enlightening about shrinking so that other people won't feel insecure around you. We are all meant to shine as children do. We were born to make manifest the glory of God that is within us. It's not just in some of us. It's in everyone. And as we let our own light shine, we unconsciously give other people permission to do the same. As we're liberated from our own fear, our presence automatically liberates others. Our Deepest Fear by Marianne Williamson. You are very important, especially to us here at the New Chemist podcasting group. You listening in is significant.
Vous êtes très important, surtout pour nous ici au New Chemist Podcasting Group. Votre écoute est significative.
Usted es muy importante, especialmente para nosotros aquí en The New Chemist Podcasting Group. Usted escuchando, es significativo.
Você é muito importante. Especialmente para nós do The New Chemist Podcasting Group. Você ouvindo, é significativo.
Είστε πολύ σημαντικοί, ειδικά για εμάς εδώ στο The New Chemist Podcasting Group. Το να ακούς είναι σημαντικό.
Sie sind sehr wichtig, besonders für uns hier bei The New Chemist Podcasting Group. Es ist wichtig, dass du zuhörst.
Je bent erg belangrijk, vooral voor ons hier bij The New Chemist Podcasting Group. Dat je meeluistert, is veelbetekenend.
You are very important, especially to us here at the New Chemist Podcasting Group. You listening in is significant. Welcome to the New Chemist Podcast.
Bienvenidos al podcast del nuevo químico.
Καλώς ήρθατε στο podcast του New Chemist. Welkom bij de podcast van The New Chemist.
Bienvenue sur le podcast du nouveau chimiste.
Bem-vindo ao podcast do novo químico.
Welcome to the New Chemist podcast. Work hard. Be value driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here rooting and cheering for you. Don't give up.
Travaillez dur. Soyez axé sur la valeur. Tu peux le faire. Vous pouvez grandir et l'apprendre. Vous pouvez être la différence dont vous et votre communauté avez besoin. N'abandonnez pas. Nous sommes ici pour vous encourager et vous encourager. N'abandonnez pas.
Trabalhar duro. Seja orientado por valores. Você consegue. Você pode crescer e aprender. Você pode ser a diferença que você e sua comunidade precisam. Não desista. Estamos aqui torcendo e torcendo por você. Não desista.
Δούλεψε σκληρά. Να οδηγείτε στην αξία. Μπορείς να το κάνεις. Μπορείτε να μεγαλώσετε και να το μάθετε. Μπορείτε να είστε η διαφορά που χρειάζεστε εσείς και η κοινότητά σας. Μην τα παρατάς. Είμαστε εδώ για να σας ζητοκραυγάσουμε. Μην τα παρατάς.
Trabaja duro. Sea impulsado por el valor. Puedes hacerlo. Puedes crecer y aprenderlo. Usted puede ser la diferencia que usted y su comunidad necesitan. No te rindas, estamos aquí animándote y animándote. No te rindas.
Werk hard. Wees waardegedreven. Je kunt het. Je kunt groeien en leren. U kunt het verschil zijn dat u en uw gemeenschap nodig hebben. Geef niet op. We zijn hier om voor je te roten en te juichen. Geef niet op.
Work hard. Be value driven. You can do it. You can grow and learn it. You can be the difference you and your community needs. Don't give up. We are here rooting and cheering for you. Don't give up. Thanks for listening. We're glad you were able to tune into this podcast. Once again, this is The New Chemist, where we discuss chemistry, which simply put is the science of change, as well as the other sciences, careers, community, research, and COVID-19. Thanks again for listening. Note, the views on this podcast represent those of my guest and I.
Purpose of these episodes not at all for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, These are not at all for medical advice or medical suggestions. Please see your local board and state certified health professional. The views of this podcast represent those of my guests and I.
Hi, Keshav. It's so good to have you on. Thanks again for joining me. So, let's get started. What have been your long-standing interest in the field of science?
Yeah, so I've been interested in science for such a long time, since childhood, really. And there's a lot of different things that brought me to it. And I think the first and most important one was just the constant kind of learning and evolving that science occurs through. And if you're someone that practices science or is part of the scientific field, you go through the same kind of development and evolution as well. You know, you are constantly learning things. Every field is constantly evolving. So you're never stagnant. You're always changing as times change, as things change, you know, everything changes. So you change with it. And I think the second thing that really drew me to science was that you're able to make a real tangible impact on people's lives. You know, with your understanding of science and your understanding of how things work, you can manipulate things and change some things so that you can, you know, potentially fix some problems or even be proactive about things to really make a significant impact upon people in the world that we live in. I think those two factors were huge reasons why I was drawn to science and can constantly pursue the scientific field.
Yeah, I completely agree with you because, you know, I think I've come to understand that the more you learn, the more you realize there's so much more to learn.
Absolutely.
As you know, I think even now, especially during this pandemic time, we can see the significance of science and the use of science in terms of developing and eventually testing the vaccination for COVID-19, and also in our daily lives, in which we go to doctors and sit down on the science teachers and on the science professors and perform research, in my case. As well as you as well. So, how do you maintain view of the bigger picture in your life and in your career in general? Given all of the difficulties which I'm sure you faced, all of the challenges and which a lot of people are facing due to the pandemic, how do you maintain view of the bigger picture?
Yeah, so just like you said, it is very, very, very difficult. And at times it's very easy to get kind of bogged down by the minutia, you know, and the everyday little challenges that we face. And, you know, especially with the pandemic, just things are magnified, you know, times 10 or even more. But I'll kind of give you an example. So recently, with medical education, what we have are like graded clinical examples. Basically, we're told to like, okay, go take a history and physical on a patient. This patient will then grade you based on, you know, how well you performed the physical and things like that. So I just recently got my grade back for one of my encounters, and I was like looking through the checklist, and I was, you know, kind of getting frustrated about like where I lost some points. You know, I was like, I mean, it's such little things that you lose points on. But then at the end of the comment section, the patient wrote, I felt very well respected, I felt heard, and I felt that if you were my doctor, I would be well taken care of. And honestly, once I read that one statement, all of my anger, all of my frustration went out the window. I was like, okay, you know what? I can get better. You know, maybe the patient's criticisms was valid, and you know, the specific techniques, you know, we can always get better at that. But at the end of the day, why I'm doing what I'm doing is for the patient, and it's to make this patient feel like they have a partner in healthcare. So taking little things like that, realizing what's the bigger goal of it all, what are you really trying to achieve, and kind of validating that made me feel like, okay, this is all worth it. Like the challenges that I'm facing, you know, academically right now, personally, just it's all for something. It's all meant for something. So just hearing that validation made me realize, okay, it's all going to be worth it.
Yeah, you know, I could say a lot of things on that. It's important to be focused on specific things in terms of having a growth mindset
which is very important, as well as, validation is important. And it plays a large role in a lot of people's growth in academia, as well as even in the lab. Having a professor say you did a good job is significant. Having a professor say you're on the right path, it does compliment. So I've read your bio, and we knew each other beforehand, before you went to medical school. So my question to you is, how have you been adaptive and creative in the field of science?
Yeah, so I mean, from where I'm at right now, I'm definitely in the, I'm still a student, I'm still in the learning phase. Before I don't think I can make any like real significant contribution yet. But the ways that I've been creative and adaptable is mainly in that learning is how I choose to understand and kind of process information. Because with science and with, just medicine, the field that I'm in, there's so much. There's just so much information. I believe one of your other guests, Tommy, he said it's like drinking water from a fire hose, and that's exactly what it is. That's exactly what it is. There's just so much. So, I'm not the type of person that can sit down and read a textbook for like 8 to 10 hours a day. So I've had to be, pretty creative with just the ways that I, understand some things or even memorize some things. There's lots of resources outside that kind of put, let's say, a specific medical condition, they'll put it in like a picture so that you're making associations with words and specific clinical symptoms and treatments, and they'll all pull it together. And like, that's how I've chosen to learn different diseases, so that when a question comes up or when a patient presents with a specific set of symptoms, I'm now making the association. So just from handling all that information, how I choose to apply it, I think has been the real way that I've been the most creative or adaptable, at least right now. Hopefully I make more significant impacts in the future so that, I can say that, I did something new, or I did something new to help someone, but as of right now, that's where I'm at.
Okay, that's good. And also, actually, before I get to that, so you said that you've been adaptive and creative in your learning style, your approach to the content. So in what ways, give us some examples of some resources that you use for people who are listening.
Yeah, so I mean, there's tons of things out there, specifically for medical students. I'm sure that they've all heard of this, or if you're going into medical school, you'll definitely hear about these. But Sketchy is a big one. That's the picture thing that I was talking about. A good tool for kind of, because inevitably with medicine, you're just gonna have to end up memorizing some things, is Anki. Basically a like kind of like a flashcard. I want to say that it's basically a flashcard device, but it has its own algorithm for spatial repetition and memory and things like that. So it's a good tool. Personally, what I've done is I've kind of brought it back to some of our engineering roots with the ways that we've kind of like understood things back in some of our intro BME classes, where we've had to just, they just kind of threw us a problem. We had to just go understand it and break it down in our own terms. So a lot of the body, if it comes to like blood flow or circulation, I'm breaking it down into like pressures and flows, and just understanding like resistances, like understanding it through that means. So if you're breaking it down that way, it kind of made more sense to me, just because it was going back to things that I've been dealing with for a couple of years now. So yeah, those are the couple of ways that I've been trying to learn everything.
That's good, dude. That's good. For me, I remember, you may not remember this, but I remember a while back, this is when we were still at Georgia Tech. I think it was me, you, and a few other people. And I started whittling off one of my wraps for the amino acids.
Yes, I do remember. Yes.
Yeah. So for me, that's kind of how I learn things. I put it to a rhythm, I make a rhyme. Also, I use associations, draw pictures and stuff like that. But for me, my main modality is through rhymes and raps and lyrics.
And we all have our own unique ways to learn things. Yeah, absolutely.
Yeah, and we have to make sure we're enjoying it. But I would just throw this out there to you. I've interviewed several other people, and one of the ways, and also graduate students and medical students, and one of the ways they have also been able to make an impact is also through mentorship. So
Mm-hmm.
maybe something you may want to consider. But I'm sure that a lot of people are trying to get into medical school, and you achieve that. So I think that's commendable. So my question to you on that note is, to this point in your studies, how have you been able to be successful? You were able to graduate, you were able to get into medical school, and so far you've been progressing. How have you been able to maintain the success that you need to progress from stages from graduation to medical school? Yeah.
Okay. Yeah. So the question itself is very focused on me, but when I think about why I'm where I am is mainly because of the people around me. I have to give a ton of people a lot of credit for helping me out through the entire process, starting with my family, who've just been there for me through everything. My mother is a physician, so she's been a wonderful role model and a leader, basically guiding me, throughout the medical field. And whenever I have any challenges, she's just like, "Yep, I faced the exact same thing. Don't worry, kid, you're on the right path." But then also my friends, who are basically my second family. They've been there for me through everything, personally, academically, any problems that I've faced. They've been there for me. They're the reason that I feel like I've grown as a person throughout the years. They've challenged me. They've supported me. They've taught me things. I've taught them things. So both just the people around me has been a major reason why I'm at where I'm at. And I don't think there's anything really special about me. I think I'm just persistent. I'm stubborn. If I fail one time, I'm gonna get right back up and keep trying until someone else, until I just can't keep going anymore. So I think that's really the only thing. I'm not like the smartest person. I'm not the most talented, but I'm persistent. And I think maybe that's probably the only thing that's kept me going, really.
That's good. Yeah, for me too. It's the same. I'm not any genius or anything of that sort, but one of the things I do say, or one of the things I do is I work hard. And I believe in being persistent. It's interesting that you use the word stubborn, because one of the professors from MIT that I interviewed said the exact same thing about himself. He said, I'm just stubborn. Yeah, I stick with it and I go along, as he was discussing his work in terms of the COVID-19 pandemic and his contributions there. Also, continuing on, how have you sought or found the right environment for you to thrive scientifically and intellectually? In other words, why did you choose Georgia Tech, and why did you choose New York Medical College to study medicine?
Well, I guess from a general point of view, when it comes to the environment, just like I said before, it's surrounding yourself by the right people. Those people have caused me to grow both personally and academically. And then when it comes to both Tech and NYMC, well, I chose Tech mainly because it was first of all away from home. I had grown up in the Northeast for 18 years at that point, so I just wanted to kind of leave and go somewhere different. And Tech was different. It's in the South, completely different in the Northeast, and there was no one that I really knew at Tech. I was kind of just on my own. There was no if I went to, say, a local university, I could always come home if things were difficult or I just wasn't feeling right. But when you're like 800 miles away, it's a little bit more difficult. So I was kind of out there on my own, which I wanted to be. I just wanted to see if I could make it.
Okay.
And then when it comes to NYMC, I think at that point I realized that, okay, I think after 4 years of being on my own, I can do it. And then I chose NYMC mainly because of the opportunities and the proximity to New York City. So, and just the opportunities that it would afford me, tons of hospitals, tons of different populations. Like, it's a diverse population, kind of the patients that we treat, whether it be in the Bronx or Manhattan or Westchester. It's whole different subsets of population. So we see a whole different disease profile. Yeah, so it's just the variety. I think that's what really drew me there.
Okay, good. Yeah, dude, diversity is so important. And I think diversity complements the learning in several ways, and not just with diverse populations. So, you said you were in New York City. So my question to you is, how have you been able to matriculate with the COVID-19 pandemic and clinicals and being in New York? How has that played, that interplay between those three variables? How has that played out?
Yeah, it's been very difficult. So I actually started medical school last year before the pandemic started. So that was kind of like normal and baseline, and just comparing last year to this year. So this year completely virtual, all classes are virtual, very few clinical encounters. So basically kind of the way med school works is your third and fourth year are purely clinical. You're in, some rotation site constantly, but first and second year, they kind of try to get your feet wet, but with just the amount of restrictions and the amount of kind of safeguards that you have to go through, it's been very difficult. Thankfully, our school has been really trying to get us still into clinic somehow, some way. So when I do go back to campus, they're gonna start giving us preceptors or mentors that we'll be able to shadow and potentially work with some patients. So it's been very difficult for sure, but I think you can't avoid the pandemic one way or another, especially if you're trying to go into medicine. It's a reality of life. So
yeah,
you kind of have to take the right safeguards and just kind of get in there and do what you can to really make a difference.
Yeah, I agree. You can't avoid every difficulty. You can't avoid. Many times you have to embrace, you have to acknowledge it, embrace it, come up with a strategy to deal with it, and progress through it. So yeah, dude, I agree. Even for me, I'm in graduate school right now, and the pandemic has affected us in terms of the formality of the instruction and even with lab interactions. So I completely agree. So given your responsibilities and accomplishments, how do you maintain a balance?
Really trying to stress in medical school right now is to avoid physician burnout and maintain some sort of work-life balance, because it's so easy to get lost. And I could definitely get better. I'm not going to say I'm an expert at it at all, but I think for right now, what's worked best for me is just physically schedule in breaks. Like I've turned into a big scheduler. I like to know what my day is going to be, and I schedule breaks. Just force myself to take a break somehow, some way. I literally will write down, okay, lunch, go make food, or go take a shower now. Like it's to that point. I'm also a big sports guy, so thankfully, like there are some sports on, and they're usually at night. So that's usually when my break is, whenever one of the games is on or something like that. So yeah, it's a nice way to like kind of schedule my break around something that's already a preset time. But other than that, sometimes you just feel like cooped up in my room all day. That's where I do all of my studying. So I just feel, locked in my room all day. So sometimes I just go out and run just to like get the blood pumping and just, see the outdoors for the first time in a couple of days. So just physically putting it in my schedule and, forcing myself to do it really, really gets me to take it. And then I think the most important thing is when you're taking your break, fully enjoy it. Sometimes what I used to do in undergrad was, okay, I'll watch the game, but I'll also like try to do some studying on the side, some like busy work that I don't really need to pay attention with. And you end up not getting either done. You don't ever watch it fully, and you don't ever get the work done properly. So I think I realized that you need to fully focus. Don't multitask. Don't try to like, do it halfway. Fully enjoy it, and then when you're done, fully get to work.
Yeah, I completely do. That's good. That's very good. I might take that on something to write that down. Because in several ways, when we decide to rest, I think we should make sure that we're intentional with resting, not trying to out of guilt I'm going to do some work on the side as well, or go to the gym. Then you carry a book with you, like a textbook or something like that. So yeah, I completely agree. I'm there with you in terms of making sure you fully rest. So, continuing on, why did you choose biomedical engineering as a field to major in during your undergraduate year? Why did you choose it?
Yeah, so it was actually you asked me for why I chose it, but it was almost a little bit of indecision. Like I wasn't really sure what I wanted to do coming out of high school. Like I knew that I wanted math to be I wanted a big math component of my future career. I also like biology, chemistry, just all of the sciences. So I knew I wanted to do something in there. And when I heard about biomedical engineering, it was a big kind of like a big mishmash of everything. You know, you'd learn this, you'd learn that, you learn a little bit of everything so that you could eventually go do something with it. You know, you're learning all these skills and you're going to take these skills and you can do whatever you want with it. So that not being forced down a specific pathway or not being like, okay, you can only do this one thing really drew me toward biomedical engineering, because it was just, you're going to learn skills. What you do with those skills is up to you. And that's what really drew me towards biomedical engineering, especially at the start.
So the versatility of the skill set, basically.
Yeah, absolutely. Yeah.
Versatility of the skill set. And you know, for me, what drew me to biomedical engineering was I was interested in device design. So at the time, so those are things that drew me. So why did you choose medicine as a field to do your doctoral studies in?
Yeah.
Why
so
medicine? Almost like the med school interview question. Why choose medicine? Why?
Yeah. And I mean, I don't know if this is the traditional med school answer, but like I remember for our BME classes towards the end, especially around, I think this was around senior year, for one of the classes, I'll never forget this. So the professor introduced a guest being like, well, this guy has sold his startup for, I don't know, tens or $20 million. So you're getting the best educate. You're getting the best guy here. I just kind of looked at myself and I was like, is this really how I want to be introduced for the rest of my life, as just how much money I made or how much money I made someone else? I was like, no, I want my self-worth to be valued from what I can do for people, for how much I can help someone. Like, yeah, of course, money is great, but that's not what I want to be known for at the end of the day. That's not, what I want to be remembered for. And that was like the eureka moment of, yeah, I don't think engineering is for me. I was kind of on the fence, and that's what really pushed me towards medicine. Just the idea that your worth is what you can do for someone else. That's what mattered more to me than anything else. And that's why I got into biomedical engineering. Like, I imagined a day where like I'd be in my own office, designing devices for patients, working with them, working with their lifestyles. And the more I learned about biomedical engineering, the more it just wasn't like that. And the more medicine was turning out to be like that, where it's, you're working with patients to come up with solutions. It's not just the general, okay, I'm the doctor, listen to me. You're working with the patient to come up with the solution that's best for them. Like, I have the information, but you're the expert in your own life. So let's work together to come up with a solution for that. That's what I realized, like, that's what I wanted. And that's what I'm getting from medicine. And that's why I chose medicine. And I'm so happy I stuck with that choice for that reason.
Right, that's very good. I completely agree. It's not this, and I agree in several ways. Our self-worth should be tied to intrinsic core values and not just monetary descriptors. Even though in many ways people say your net worth is tied to those monetary descriptors.
Yeah.
But your self-worth, I think, should be tied to core values. That's just my perspective, and it seems like it's yours as well. So, along the same lines, what advice do you have to those wanting to pursue the field you are currently studying in? So you just said that you're interested in medicine, and your interest is tied to how you want to help people and how you want there to be a dialogue in the clinical environment in which both of you approach the situation, you with your expertise, the patient with their situation, expert in how they're feeling, and you come to some beneficial conclusion. So what advice do you have to those wanting to pursue the field you're currently studying in?
Yeah, so there's a lot of kind of aspects to that. So I guess the first thing that I would say is, yes, it's great that you want to help someone, and I'm sure that's the core of everyone who wants to go into medicine. Yes, we all want to help people, but if that's the only reason you're going into medicine may not be it for you. There has to be some sort of kind of selfish motivator that's driving you towards medicine. And for me, it was the constantly learning, constantly developing. Like, I want to be a better person 10 years from now than I am today. I want to be much better. And medicine allows me to do that. So I would say really make sure that medicine is for you, because it's a long grind, from the day you enter medical school till the day you get your first real job is probably close to like 10 years. So to go through 10 years of school and then residency and then fellowship or whatever extra schooling you want to do, you have to make sure that there's something in it for you, that there's some internal gain that you are getting from medicine that no other field can give you. And that's what will really drive you to be the best physician or whatever role of healthcare you want to be. Other than that, be patient and be persistent. It's a long grind. Like a lot of people, what they do is they go into a career right out of college, and then once they're done with that, they choose to commit to medical school. So there's no real rush, being like, I have to go straight into medical school right out of undergrad. Absolutely not. I think the average age of my incoming class was 27. So if you're graduating around 23, 24, people have worked for a couple of years. A lot of students have children, have families. So, like, have a life outside of medical school. If you want to have a life before medical school, that's absolutely fine. Just be patient. If you have to apply multiple times, if you have to redo some coursework, redo the MCAT, it's all perfectly fine. It's a long journey. No one really cares if you did it right the first time. Just do the best that you can in every aspect. That's basically it.
Good, that's good. Being patient and persistent, because at the end of the day, we're all on a journey. And also, our paths are different. So just because one person went to medical school in 2 years after undergrad, or 1 year, or did the traditional, or just went directly after, doesn't mean you have to do the same.
Absolutely. All that matters is the care that you can give to the patient. So whatever gets you to do the best for that, that's all that matters. Doesn't matter what path you took. You said that perfectly.
Yeah. So, Keshav, what has been some of the most beneficial advice you have received?
So advice that I've received. So I wouldn't say this has been explicitly told to me, but I think what all of my mentors have tried to really emphasize upon me or get me to do it. I think the best way to sum it up is, fall in love with the process of becoming great. Really enjoy really enjoy the kind of struggle that you're going through now. It's for some other bigger picture goal. Like, yes, me, studying right now is to eventually become a doctor. But if I don't enjoy it now, I'm not going to enjoy being that physician. I'm not going to enjoy the work that I'm eventually going to have to do. So really enjoy the struggle, the hard work, all the skills and experiences that you're learning, all the kind of mistakes that you make throughout the process, because that's what you're eventually going to learn from. You learn more from your mistakes than all of your successes. So really just enjoy that process. Get good at just getting back up after you make a mistake, and keep going. That's the only way that you're going to learn. And I think people showing me that really taught me to be persistent and taught me to just keep going no matter what, because that's the only right thing to do. Just keep going.
Yeah, that's good. Yeah, it's important to embrace the struggle and our process to become doctors, lawyers, accountants, professors, technicians. It's important to be a person of value, not just someone who can bring value and someone who has core values and who lives. Yes, and I think it's also important to watch out for the destination fallacy, in which you think, I must arrive to this place, then I'll be happy. Or I must arrive to this next phase, then I'll be happy.
Absolutely.
And, dude. So my last question for you, Keshav, before we conclude, perfect scenario. Given this pandemic, I take it we all have had situations where we could say, I wish something was a little different. If you had to come up with a perfect scenario in the next 5 years, what would it be? Within the context of your medical education and life, what would it be?
That's a great question. And I think my first, I don't know if this would be my answer maybe in a couple of days, but my first gut reaction went to kind of something that I've been thinking about for a while, is that this whole pandemic has kind of taught all of us the importance of health and hygiene. Just taking everything very seriously, it's very easy to catch a cold or catch the flu. We see how easy it is to catch COVID just from going outside, going to a restaurant. You could still be masked up and you would take all the proper precaution. You could still still catch a virus. So I think the perfect situation for me right now is that we all take our health a lot more seriously. We understand how fragile it is and how truly important and precious our health is, and how much we need to take care of it for the long term. I think for me right now, that's the answer that I would say is a perfect scenario.
Oh, that's good. It's important for everyone to realize that their health and your health is very important. So, Keshav, thanks again for joining me today. It is good to have you on.
Welcome to the new Student Pharmacists podcast experience. We are so glad you are listening in. Please note, the views of this podcast represent those of my guest, S, and I note, purpose of these episodes not at all, for advice or medical suggestions. These are aimed to provide support for peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice, or for medical suggestions. Please see your local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions. Sodium, Na, normal range, 135 to 145 mg/L hyponatremia, sodium, 135 mg/L, causes, SHAD, heart failure, liver cirrhosis, diuretics. Symptoms, confusion, seizures, coma, particularly if Na, 120 mg/L. Treatment, O mild to moderate, fluid restriction. O severe, Na, 110 mg/L hypertonic saline, 3% NaCl, at 100 ml over 10 minutes, followed by slower infusion. Onset, acute neurological symptoms may arise within hours if sodium drops rapidly. Hyponatremia, sodium, 145 mg/L, causes, dehydration, excess sodium intake, diabetes insipidus. Symptoms, thirst, weakness, seizures, coma. Treatment, O mild to moderate, oral water or D5W, 5% dextrose in water, 4. O severe, 0.45% NaCl, half normal saline, to gradually lower sodium. Onset, symptoms can develop within hours to days, depending on the speed of the imbalance. Key caution, avoid rapid correction of hyponatremia to prevent cerebral edema. Potassium, K, normal range, 3.5-5.0 mg/L hypokalemia, potassium, 3.5 mg/L, causes, diuretic use, vomiting, insulin administration. Symptoms, muscle weakness, cramps, arrhythmias, for example, U waves on ECG. Treatment, O mild to moderate, oral potassium chloride, 20 to 40 mg per day. O severe, K, 2.5 mg/L for potassium chloride, 10 mg/hour, in cases with ECG changes or muscle paralysis. Onset, symptoms develop gradually as potassium levels decrease, typically over days. Hypokalemia, potassium, 5.0 mg/L, causes, renal failure, acidosis, potassium-sparing diuretics. Symptoms, muscle weakness, bradycardia, arrhythmias, for example, peaked T waves on ECG. Treatment, O stabilize the heart, calcium gluconate 1 gram for over 5 to 10 minutes to protect the myocardium. O shift potassium into cells, insulin, 10 units for, with 50 ml of D50 to move K into cells. O eliminate potassium, sodium polystyrene sulfonate, K-oxalate, 15 to 30 grams orally or rectally to excrete K. Onset, life-threatening arrhythmias may develop within minutes to hours, requiring rapid intervention. Calcium, Ca², normal range, 8.6-10.2 mg/dl hypercalcemia, calcium, 8.6 mg/dl, causes, hypoparathyroidism, vitamin D deficiency, renal disease. Symptoms, tetany, muscle cramps, seizures, Kvostex sign, Traceo's sign. Treatment, mild to moderate, oral calcium supplements, for example, calcium carbonate or calcium citrate. Severe, symptomatic for calcium gluconate 1 to 2 grams over 10 to 20 minutes. Onset, neuromuscular symptoms like tetany and spasms can occur within hours of significant hypercalcemia. Hypercalcemia, calcium, 10.5 mg/dl, causes, hyperparathyroidism, malignancy, prolonged immobilization. Symptoms, weakness, polyuria, polydipsia, arrhythmias. Treatment, mild to moderate, for saline to enhance renal calcium excretion, along with diuretics like furosemide. Severe, Ca², 14 mg/dl bisphosphonates, for example, palmidronate, to inhibit bone resorption. Onset, hypercalcemia can develop slowly over weeks but can cause rapid symptoms if levels rise quickly. Phosphate, Po3, normal range, 2.5-4.5 mg/dl hyperphosphatemia, phosphate, 2.5 mg/dl, causes, alcoholism, malnutrition, diabetic ketoacidosis. Symptoms, weakness, respiratory failure, rhabdomyolysis. Treatment, mild to moderate, oral phosphate supplements like Nutrafos, 250 to 500 mg po, 1 to 2 times /day. Severe, Po3, 1 mg/dl 4-phosphate at 0.08-0.16 ml/kg over 4 to 6 hours. Onset, symptoms can develop over days as phosphate levels drop. Hyperphosphatemia, phosphate, 4.5 mg/dl, causes, chronic kidney disease, CKD, rhabdomyolysis, tummolysis syndrome. Symptoms, often asymptomatic, but can lead to hypercalcemia and calcification in tissues. Treatment, dietary phosphate restriction and use of phosphate binders like sevelamer, 800 to 1600 mg with meals, or calcium acetate, 667 mg with meals, to reduce absorption. Onset, symptoms usually develop over days to weeks, especially in chronic kidney disease. Magnesium, Mg², normal range, 1.5-2.5 mg/L hypomagnesemia, magnesium, 1.5 mg/L, causes, diuretic use, alcoholism, malabsorption. Symptoms, neuromuscular irritability, seizures, arrhythmias. Treatment, mild to moderate, oral magnesium supplements like magnesium oxide, 400 to 800 mg daily. Severe, symptomatic for magnesium sulfate, 1 to 2 grams over 15 minutes, for rapid correction. Onset, symptoms can develop within hours to days of depletion. Hypomagnesemia, magnesium, 2.5 mg/L, causes, renal failure, excessive magnesium intake. Symptoms, lethargy, muscle weakness, hypertension, cardiac arrest. Treatment, 4-calcium gluconate, 1 to 2 grams over 10 minutes, to counteract magnesium's effects on the heart. 4 fluids and diuretics to promote magnesium excretion. Onset, hypomagnesemia is usually gradual, but severe cases, Mg², 5 mg/L, require urgent intervention due to the risk of cardiac arrest. Summary for exam prep: normal electrolyte ranges: O sodium 135 to 145 mg/L, O potassium 3.5-5.0 mg/L, O calcium 8.6-10.2 mg/DL, O phosphate 2.5-4.5 mg/DL, O magnesium 1.5-2.5 mg/L. Treatment methods: O4 fluids, NS, D5W, etc., for dehydration and hyponatremia. O oral /4 potassium for hypokalemia and insulin for hyperkalemia. O calcium gluconate for both hyperkalemia and hypercalcemia. O phosphate binders for hyperphosphatemia. Onset of action: O electrolyte imbalances can develop over hours, acute, or days, chronic. O4 treatments like calcium gluconate or insulin have rapid onset, within minutes, while oral supplements work over several days. Chapter 1: The Kingdom of Balance. In the Kingdom of Balance, everything was measured carefully to maintain harmony. The residents of the kingdom were vigilant about the critical ranges of their vital electrolytes. King sodium and queen potassium's rule depended on these exact values, as any deviation could wreak havoc across the land. Sodium: the ideal range for sodium was between 135 to 145 mg/L, and any drop below this resulted in the condition of hyponatremia, which made the people weak and confused. On the other hand, when sodium rose above 145 mg/L, hyponatremia set in, causing severe dehydration and even seizures in the people of Sumetria. Potassium: the kingdom's warriors, the cardiacus musculus, required potassium levels to be tightly controlled between 3.5-5.0 mg/L. Anything above 5.0 mg/L was considered hyperkalemia, which could lead to dangerous heart arrhythmias, while levels below 3.5 mg/L resulted in hypokalemia, causing weakness, fatigue, and cramps. When the kingdom faced an electrolyte imbalance, time was of the essence. The onset of action for these conditions was swift, within minutes to hours, depending on the severity of the disturbance. Thus, the hydration knights, armed with 4 fluids like normal saline for sodium imbalances or potassium supplements for hypokalemia, needed to act quickly. Treatment options: for hyponatremia, the knights administered hypertonic saline in severe cases, with careful monitoring to prevent central pontine myelinolysis. For hyperkalemia, the warriors would use calcium gluconate to stabilize the heart, followed by insulin with glucose or albuterol to shift potassium into cells, and sodium polystyrene sulfonate, K-oxalate, to eliminate potassium from the body. The future trends in Sumetria involved new ion transporters that could regulate electrolyte balance more effectively and minimize the need for frequent IV therapy, which was labor-intensive. Researchers were working on developing advanced homeostasis devices that would help detect imbalances early. Chapter 2: The Herbalist's Forest. As the herbalist walked through the herbalist's forest, she knew that time and dosage were everything. Each herb had an onset of action and a range of efficacy. She often measured the effectiveness of each plant by its therapeutic window, the range in which the herb was effective but not dangerous. Ginger, a popular herb for treating nausea, ginger took 30 minutes to 2 hours to take effect. The therapeutic range for ginger was typically 250 to 1000 mg per day, but doses higher than this increased the risk of bleeding, especially when combined with anticoagulants. 9 source. Green tea, known for its antioxidant properties and cardiovascular benefits. Green tea's onset could vary depending on the form taken. Capsules took around 30 to 60 minutes for onset, while tea took about 15 to 30 minutes. 9 source. However, too much green tea, over 400 to 500 mg of caffeine, could lead to jitteriness, increased heart rate, and insomnia. 9 source. Turmeric, often used to reduce inflammation, turmeric took 1 to 2 weeks of consistent use to show its benefits. The effective range for turmeric was around 400 to 600 mg of curcumin daily, but exceeding 1000 mg/day could lead to gastrointestinal distress and bleeding. 9 source. Treatment options. For those who experienced adverse effects from these herbs, charcoal preparations or antiemetics could be used to counter the toxic effects of overdose, especially in the case of misused herbal blends. Future trends in the herbalist's forest involved the development of phytochemical interactions software, which could predict adverse herb-drug interactions with incredible accuracy, helping travelers avoid dangerous combinations. Chapter 3. The realm of obesitas. The sprawling realm of obesitas had long been grappling with the rising epidemic of BMI values above the healthy range. The ranges for classifying the people's health were established long ago. A BMI of 18.5-24.9 kg/m² was considered normal. A BMI between 25-29.9 kg/m² indicated overweight, while a BMI of 30 kg/m² or more signified obesity. 10 source. The onset of obesity-related complications, such as diabetes, hypertension, and cardiovascular disease, depended on the degree of obesity and the length of time the person had been overweight. For instance, type 2 diabetes could develop over several years of high BMI, while hypertension often manifested within 1 to 3 years of entering the obesity range. 10 source. Treatment options. The people of obesitas had access to both short-term pharmacotherapy, such as phentermine, which acted within a few hours, and long-term therapies like GLP-1 agonists, semaglutide, which could take several weeks to start showing their effects. 10 source. Surgical options like gastric bypass had immediate effects on food intake, but the full benefit of weight loss was seen over 12 to 18 months. The future trends in obesitas were promising. Researchers were working on developing personalized medicine for obesity, using genetic markers to tailor drug therapy and dietary plans for each individual. Additionally, wearable technology that monitored calorie intake and expenditure in real time was on the horizon, making it easier for the people to manage their weight long term. Chapter 4. The Valley of Toxicity. The Valley of Toxicity was a dangerous place, where one could never be too careful with dosages. The minions of the Poison King, opium, acetaminophen, and ironica, each had their deadly ranges and timescales. Acetaminophen. The kingdom's scholars had discovered that the maximum safe daily dose of acetaminophen was 4000 mg/day for adults, and toxicity began to occur after doses exceeding the 7th of May 2010 g. The onset of liver damage from acetaminophen overdose could take 24 to 72 hours, making it a silent but deadly foe. 11 source. Ironica, iron toxicity occurred when ingestion exceeded 20 mg/kg, with severe poisoning likely at doses above 40 mg/kg. Symptoms of toxicity could appear as soon as 30 minutes to 6 hours after ingestion. 11 source. Treatment options. For acetaminophen overdose, the antidote N-acetylcysteine was most effective if given within 8 to 10 hours, though it could still be beneficial if given up to 24 hours later. 11 source. For iron toxicity, deferoxamine was used to chelate iron, with effectiveness seen within a few hours of administration. 11 source. Future trends in the valley involved nanotechnology antidotes that could be tailored to specific toxic agents, providing quicker and more targeted responses to overdoses. Additionally, wearable biosensors were being developed to detect toxic levels of drugs in real time, alerting users and healthcare providers before symptoms even appeared. Chapter 5. The fields of hypersensitivity. In the fields of hypersensitivity, the immune system was on high alert, ready to pounce at any perceived invader. The range of responses varied based on the type of hypersensitivity. Type I hypersensitivity, Ig-mediated. This was the most dangerous of the immune responses, as it could lead to anaphylaxis within minutes of exposure to allergens such as penicillin. The immune system overreacted, causing symptoms like swelling, difficulty breathing, and a rapid drop in blood pressure. 8 source. Type 4 hypersensitivity, delayed response. In contrast, Type 4 reactions took days to weeks to manifest. A classic example was Stevens-Johnson syndrome, SJS, where the skin would blister and peel away, often several days after starting a medication like carbamazepine. 8 source. Treatment options. For Type I reactions, immediate administration of epinephrine was crucial, followed by antihistamines and corticosteroids. 8 source. The onset of action for epinephrine was within minutes, providing a life-saving reversal of anaphylaxis. For Type 4 reactions, corticosteroids and discontinuation of the offending agent were the mainstays of treatment. The healing process could take several weeks depending on the severity of the reaction. 8 source. The future of hypersensitivity management lay in personalized immunotherapy, where genetic screening could predict an individual's likelihood of developing a drug allergy, allowing for safer prescribing practices from the start. Epilogue. The eternal balance. The chronicles of pharma were far from over. Each chapter of the journey reinforced the overarching theme that health, like the delicate balance in symmetria, was a fragile equilibrium. The travelers learned that it wasn't just about knowing the cures and treatments but about understanding when and how to use them. As technology advanced in pharmacia, the people saw glimpses of a future where balance could be monitored in real time, where antidotes could be tailored to the individual, and where the mistakes of the past could be avoided through knowledge and foresight. In this future, the line between health and disease would no longer be crossed unknowingly, for the people would be armed with the wisdom of the ages and the tools of tomorrow. And so, the chronicles of pharma continue, with each traveler a steward of balance, ever watchful of the delicate interplay between nature, medicine, and the human body. The Chronicles of Pharma, A Journey Through the Realms of Health. Chapter 1. The Kingdom of Balance. In the Kingdom of Balance, the harmony of sodium and potassium was maintained through strict dosing protocols, ensuring the people never strayed from the narrow path of equilibrium. Sodium and potassium, sodium supplements. In times of hyponatremia, the hydration knights administered hypertonic saline, 3% NaCl, starting at 100 ml over 10 minutes, followed by slower infusions if needed to avoid osmotic demyelination syndrome. For less severe cases, isotonic saline, 0.9% NaCl, was given at a rate of 500 to 1000 ml/hour until symptoms subsided. Potassium supplements. When hypokalemia threatened the kingdom, potassium chloride was provided. The standard oral dosing was 20 to 40 mg to raise serum potassium by 0.5-1 mg/L. In emergencies, where the heart was at risk, 4 potassium chloride was given at 10 mg/hour, with careful monitoring to prevent hyperkalemia. In cases of hyperkalemia, the kingdom's response was swift and strategic. First, calcium gluconate, 1 gram 4, was administered over 5 to 10 minutes to protect the heart from arrhythmias. Then, a combination of insulin, 10 units 4, with dextrose, 50 ml of 50% glucose, was used to shift potassium into cells, followed by sodium polystyrene sulfonate, K-oxalate, in doses of 15 to 30 grams orally to bind and excrete potassium. Chapter 2. The Herbalist's Forest. Within the herbalist's forest, precise dosing of herbs was key to unlocking their healing powers. The herbalist always warned of the thin line between medicine and poison. Ginger. For the treatment of nausea, ginger root was commonly prescribed at doses of 250 to 1000 mg daily in divided doses. Travelers suffering from motion sickness took 500 mg 30 minutes before their journey, with an additional 500 mg every 4 hours as needed. However, the herbalist always cautioned against exceeding 4 grams per day, as it could lead to bleeding when combined with anticoagulants. 9 source. Green tea. For weight loss and cardiovascular health, green tea extract was effective at doses of 250 to 500 mg of standardized extract per day, which typically contained 200 to 400 mg of polyphenols. Drinking the tea itself required 3 to 5 cups daily to reach similar benefits. The herbalist always warned that exceeding 500 mg day of caffeine could result in insomnia and palpitations. 9 source. Turmeric. The golden turmeric, famed for its anti-inflammatory properties, was prescribed at doses of 400,600 mg of curcumin up to 3 times a day. The herbalist insisted that doses above 1000 mg day should only be used with caution, especially in those taking anticoagulants or with gallbladder disease. 9 source. Chapter 3. The realm of obesitas. In obesitas, the struggle to maintain healthy body weight was supported by various pharmacological interventions, each with its precise dosing regimens. Phentermine. The powerful appetite suppressant, phentermine, was given in doses of 15-37.5 mg orally, taken once daily in the morning to avoid insomnia. The people of obesitas were cautioned that phentermine should only be used for up to 12 weeks, as its long-term use carried risks of tachycardia and hypertension. 10 source. Semaglutide. Wegovy semaglutide, a GLP-1 receptor agonist, was dosed once weekly as a subcutaneous injection, starting at 0.25 mg for the first 4 weeks, then increased to 0.5 mg, and eventually reaching a maintenance dose of 2.4 mg once weekly. This slow titration helped minimize side effects like nausea and vomiting. Semaglutide was highly effective, with average weight loss of 15 to 20% after 1 year of use. 10 source. Orlistat, Ali, Xenical Orlistat, a fat absorption inhibitor, was available in 60 mg, Ali, OTC, and 120 mg, Xenical, prescription, doses, taken 3 times daily with meals containing fat. The herbalist reminded the people that orlistat could cause gastrointestinal side effects, like oily stools, and they should take a multivitamin 2 hours before or after dosing to prevent fat-soluble vitamin deficiencies. 10 source. Naltrexone / bupropion, contrav. The combination therapy naltrexone, 8 mg, and bupropion, 90 mg, was initiated with 1 tablet in the morning, and titrated over 4 weeks to a dose of 2 tablets twice daily. This therapy worked on the brain's reward system to suppress cravings, with an average weight loss of 5 to 10% of body weight after 56 weeks. 10 source. Chapter 4. The Valley of Toxicity. In the treacherous Valley of Toxicity, dosing of antidotes was a matter of life and death. The people knew that only precise doses could reverse the effects of the Poison King's agents. Acetaminophen overdose. For those who had fallen victim to acetaminophen, the antidote N-acetylcysteine, NAC, was given. The standard dosing protocol was a loading dose of 140 mg/kg orally, followed by 70 mg/kg every 4 hours for a total of 17 doses. If given within 8 to 10 hours of ingestion, NAC could prevent liver failure. 1 source. Iron overdose. For the metallic poison of Ironica, the antidote was deferoxamine, given at a dose of 15 mg/kg/hour via 4 infusion, up to a maximum of 6,000 mg per 24 hours. Early administration within 6 hours of ingestion could prevent fatal organ damage. 1 source. Opioid overdose. The warriors who succumbed to opium were revived using the powerful antidote naloxone. In cases of opioid overdose, 0.4 to 2 mg of naloxone was administered intravenously, with repeat doses every 2 to 3 minutes until respiratory function was restored. In severe cases, continuous infusions of 0.4 mg/hour were used to maintain reversal. 1 source. Chapter 5. The fields of hypersensitivity. In the fields of hypersensitivity, where the immune system could attack at any moment, the people relied on life-saving medications to counter the overreactions. Anaphylaxis. The most feared reaction in the fields was anaphylaxis, which could strike within minutes. The epinephrine warriors carried epinephrine autoinjectors, dosed at 0.3 mg for adults and 0.15 mg for children under 30 kg. This had to be administered immediately, and if symptoms persisted, a second dose could be given after 5 to 15 minutes. 8 source. Corticosteroids and antihistamines. Following the initial epinephrine treatment, the people used antihistamines such as diphenhydramine, 25 to 50 mg orally or 4, to block histamine release, and corticosteroids, prednisone 40 to 60 mg orally, to prevent delayed reactions. Though these didn't act as quickly as epinephrine, they were essential for long-term management. 8 source. Stevens-Johnson syndrome, SJS, and toxic epidermal necrolysis, 10 for severe type 4 hypersensitivity reactions, such as SJS and 10, immediate cessation of the offending drug was critical. Treatment included 4 fluids, pain management, and topical steroids for skin care. If the patient's condition was severe, 4 immunoglobulins, 2 grams/kg, were sometimes used to halt the immune attack. 8 source. Epilogue. The balance of doses. As the travelers reflected on their journey through the realms of pharmacia, they came to understand that health was not merely a matter of treatment, it was about precision. Every potion, herb, and antidote had a dose, a fine line between healing and harm. Whether balancing sodium and potassium, dosing weight loss drugs, or administering life-saving antidotes, the people of pharmacia realized that their survival depended on this delicate science. With this knowledge in hand, they returned to their lives, wiser and more prepared to handle the delicate balance of health. They knew that with the right dose at the right time, even the most dangerous afflictions could be conquered. Sodium, Na, normal range, 135 to 145 mg/L. Hyponatremia, sodium, 135 mg/L, causes, SHIAD, heart failure, liver cirrhosis, diuretics. Symptoms, confusion, seizures, coma, particularly if Na, 120 mg/L. Treatment, O mild to moderate, fluid restriction. O severe, Na, 110 mg/L. Hypertonic saline, 3% NaCl, at 100 ml over 10 minutes, followed by slower infusion. Onset, acute neurological symptoms may arise within hours if sodium drops rapidly. Hyponatremia, sodium, 145 mg/L, causes, dehydration, excess sodium intake, diabetes insipidus. Symptoms: thirst, weakness, seizures, coma. Treatment: O mild to moderate, oral water or D5W, 5% dextrose in water, 4. O severe, 0.45% NaCl, half normal saline, to gradually lower sodium. Onset: symptoms can develop within hours to days, depending on the speed of the imbalance. Key caution: avoid rapid correction of hyponatremia to prevent cerebral edema. Potassium, K, normal range, 3.5-5.0 mg/L hypokalemia, potassium, 3.5 mg/L, causes, diuretic use, vomiting, insulin administration. Symptoms: muscle weakness, cramps, arrhythmias, for example, U waves on ECG. Treatment: O mild to moderate, oral potassium chloride, 20 to 40 mg per day. O severe, K, 2.5 mg/L for potassium chloride, 10 mg/hour, in cases with ECG changes or muscle paralysis. Onset: symptoms develop gradually as potassium levels decrease, typically over days. Hypokalemia, potassium, 5.0 mg/L, causes, renal failure, acidosis, potassium-sparing diuretics. Symptoms: muscle weakness, bradycardia, arrhythmias, for example, peaked T waves on ECG. Treatment: O stabilize the heart, calcium gluconate 1 gram for over 5 to 10 minutes to protect the myocardium. O shift potassium into cells, insulin, 10 units for, with 50 ml of D50 to move K into cells. O eliminate potassium, sodium polystyrene sulfonate, K exhalate, 15 to 30 grams orally or rectally to excrete K. Onset: life-threatening arrhythmias may develop within minutes to hours, requiring rapid intervention. Calcium, Ca², normal range, 8.6-10.2 mg/dl hypercalcemia, calcium, 8.6 mg/dl, causes, hypoparathyroidism, vitamin D deficiency, renal disease. Symptoms: tetany, muscle cramps, seizures, Kvostex sign, Traceo's sign. Treatment: O mild to moderate, oral calcium supplements, for example, calcium carbonate or calcium citrate. O severe, symptomatic for calcium gluconate 1 to 2 grams over 10 to 20 minutes. Onset: neuromuscular symptoms like tetany and spasms can occur within hours of significant hypercalcemia. Hypercalcemia, calcium, 10.5 mg/dl, causes, hyperparathyroidism, malignancy, prolonged immobilization. Symptoms: weakness, polyuria, polydipsia, arrhythmias. Treatment: O mild to moderate, for saline to enhance renal calcium excretion, along with diuretics like furosemide. O severe, Ca², 14 mg/dl bisphosphonates, for example, palmidronate, to inhibit bone resorption. Onset: hypercalcemia can develop slowly over weeks but can cause rapid symptoms if levels rise quickly. Phosphate, Po3, normal range, 2.5-4.5 mg/dl hyperphosphatemia, phosphate, 2.5 mg/dl, causes, alcoholism, malnutrition, diabetic ketoacidosis. Symptoms: weakness, respiratory failure, rhabdomyolysis. Treatment: O mild to moderate, oral phosphate supplements like Nutrafos, 250 to 500 mg po, 1 to 2 times /day. O severe, Po3, 1 mg/dl for phosphate at 0.08-0.16 ml/kg over 4 to 6 hours. Onset: symptoms can develop over days as phosphate levels drop. Hyperphosphatemia, phosphate, 4.5 mg/dl, causes chronic kidney disease, CKD, rhabdomyolysis, tumor-lysis syndrome. Symptoms, often asymptomatic, but can lead to hypercalcemia and calcification in tissues. Treatment, dietary phosphate restriction and use of phosphate binders like sevelamer, 800 to 1600 mg with meals, or calcium acetate, 667 mg with meals, to reduce absorption. Onset, symptoms usually develop over days to weeks, especially in chronic kidney disease. Magnesium, mg², normal range, 1.5-2.5 mg/L. Hypomagnesemia, magnesium, 1.5 mg/L, causes diuretic use, alcoholism, malabsorption. Symptoms, neuromuscular irritability, seizures, arrhythmias. Treatment, mild to moderate, oral magnesium supplements like magnesium oxide, 400 to 800 mg daily. Severe, symptomatic for magnesium sulfate, 1 to 2 grams over 15 minutes, for rapid correction. Onset, symptoms can develop within hours to days of depletion. Hypomagnesemia, magnesium, 2.5 mg/L, causes renal failure, excessive magnesium intake. Symptoms, lethargy, muscle weakness, hypertension, cardiac arrest. Treatment, 4 calcium gluconate, 1 to 2 grams over 10 minutes, to counteract magnesium's effects on the heart. 4 fluids and diuretics to promote magnesium excretion. Onset, hypomagnesemia is usually gradual, but severe cases, mg², 5 mg/L, require urgent intervention due to the risk of cardiac arrest. Summary for exam prep, normal electrolyte ranges, sodium, 135 to 145 mg/L. Potassium, 3.5-5.0 mg/L. Calcium, 8.6-10.2 mg/dl. Phosphate, 2.5-4.5 mg/dl. Magnesium, 1.5-2.5 mg/L. Treatment methods, 4 fluids, NS, D5W, etc., for dehydration and hyponatremia. Oral /4 potassium for hypokalemia and insulin for hyperkalemia. Calcium gluconate for both hyperkalemia and hypercalcemia. Phosphate binders for hyperphosphatemia. Onset of action, electrolyte imbalances can develop over hours, acute, or days, chronic. 4 treatments like calcium gluconate or insulin have rapid onset, within minutes, while oral supplements work over several days. Thanks again for listening. We are so glad you are listening in. Please note, the views of this podcast represent those of my guest, and I note, purpose of these episodes not at all, for advice or medical suggestions. These are aimed to provide support for peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice, or for medical suggestions. Please see your local state and board certified physician, PA or NP, and pharmacist for medical advice and suggestions.
Purpose of these episodes not at all, for advice or medical suggestions. These are aimed to provide support to peer pharmacists in training in educational and intellectually stimulating ways. Again, these are not at all for medical advice or medical suggestions. Please see your local board and state-certified health professional. The views of this podcast represent those of my guests and I.